Okay, aku boleh share.
Do you know how to share slides? Okay, found it. Okay, can you see slides?
Yes, yes.
All right, thank you. So the topic that was given to me is liver cirrhosis. So that's what I'm going to talk about in the next half an hour. The content of my talk will probably be functions of the liver. Oops.
Hai, dah lupa Dr. Haniza ni. Pernah dengar, saya pernah pergi CDE Liver.
Dr. Haniza, you are muted.
So thank you again for. So for the next half an hour or so, I want to talk about liver cirrhosis, and things that I would like to cover would be probably functions of the liver, hepatitis, cirrhosis, complications of cirrhosis, which includes ascites, GI, varicose bleeding, and encephalopathy. And I hope at the end of this session, maybe I can enlighten all of you in how you can help us in managing our patients. So, you know, the liver, we only have one liver. It's the biggest organ in the body. It weighs around 1.5 kilograms and it's located at your right hypochondrium region below your right rib cage. Yeah. So if you actually look at the liver closely, it divides into lots of hepatocytes and hepatic lobule, which is lined by the stellate cells and the Kupffer cells. And looking more microscopically, you can see that the hepatocytes and the portal triad, which is involved portal vein, biliary duct, and hepatic artery. So the blood supply of the liver is divided into two main blood supplies, mainly the portal vein and the hepatic artery, 80% by the portal vein and 20% by the hepatic artery, and outside the liver, it will be divided into hepatic veins. Because it's the biggest function in the liver, the functions of the liver is vast. So the main, one of the few functions of the liver will include metabolizers or break down nutrients from food to produce energy when needed. Our patients with liver cirrhosis, when the liver is damaged, they bruise easily and they bleed easily as well. It produces bile in production and absorbs fat. And of course, it produces vitamins, mainly vitamins A, D, E, and K. So when one goes to the ward to look at the patient, so you can always look at the liver function test. So the liver function test comprises of a few tests, which is the transaminases, your ALT and your AST, your gamma GT, ALP, bilirubin, albumin, and also INR. These transaminases, your ALT and AST, detects or will tell you things about if there's any evidence of hepatocellular injury. Also, AST also will tell you a bit about skeletal and muscle as well. Gamma GT2 gives an indication of hepatocellular injury. Alkaline phosphatase, mainly cholestatic, albumin and INR will give you an indication of the synthetic function of the liver. And of course, with any derangement of liver enzymes, you can detect whether the patients have evidence of hepatitis or liver disease. So what is hepatitis? So hepatitis comes from a Greek word. Hepa means liver, we all know that, and itis means inflammation. So hepatitis means inflammation of the liver. And this condition can be self-limiting, but it can, with ongoing evidence of inflammation, and its healing processes, it can lead to fibrosis, scarring, and also cirrhosis. So there are many causes of hepatitis. The main cause in our country and in this part of the world would be viral hepatitis, mainly hepatitis B and hepatitis C. Others would include things like alcohol, drugs and toxins, autoimmune, and the new upcoming etiology of liver disease now would be the non-alcoholic fatty liver disease, otherwise known as metabolic liver disease. There are also other causes of obstruction which can lead to hepatitis, maybe obstruction from a tumor or obstruction from stones, veno-occlusive disease, Budd-Chiari syndromes, and hemochromatosis. Let me tell you about cirrhosis now. So cirrhosis, also a Greek word which means cirrhose, which is orangish, osis, which means condition. So basically what it's telling you is that the definition of cirrhosis is a diffuse process characterized by liver necrosis, the liver cell death, fibrosis, and conversion of normal liver architecture into structurally abnormal nodules that lack of normal globular organization. So you can appreciate seeing that the normal, nice liver with prolonged inflammation, prolonged hepatitis, can lead to what is called as cirrhosis. So you can see, you can appreciate the irregular margins of this liver and the nodules that has formed with prolonged inflammation. So the progression of healthy liver to fibrosis, cirrhosis, and with any evidence reasons of cirrhosis can lead to liver carcinoma. So this progression take over 10 to 20 years. And of course, if you have more risk factors, more inflammation, if you have viral hepatitis, fatty liver, you consume alcohol, so things that are hepatotoxic, the progression can be much faster. And if you look under the microscope, looking at the metavase core, the evidence of no fibrosis, a normal liver, which includes normal healthy hepatocytes, can progress on to fibrosis if you can appreciate this little inflammation around the portal tracts, and this inflammation can progress further from one portal tract to the other portal tract, leading to this nodular looking cirrhosis as the end product. So we all know from chronic liver disease, there can be compensated cirrhosis. What I meant by compensated cirrhosis is there's no evidence of complications of this cirrhosis. And with compensated cirrhosis can lead to decompensated cirrhosis. And when I talk about decompensated, are the ones that you can see in our wards where the patient comes in with jaundice, with ascites, with upper GI bleed, or with encephalopathy, confusion. So again, chronic hepatitis, at this stage, you can probably treat your patients if they have hepatitis B or C with antivirals, autoimmune with steroids, Wilson's disease with chelators. You may want to give vaccination to your patients who have not been vaccinated yet, hepatitis B mainly, and with prolonged inflammation, if they're not looked after or managed properly, they can lead to cirrhosis. And with cirrhosis, complications of cirrhosis happening, ascites, upper GI bleed, jaundice, and they can decompensate further. Or with cirrhosis, it can lead to liver cancer, and that's the end. Either they pass away from that, or we can offer them other modalities, i.e. transplant treatment. So now I want to talk about complications in cirrhosis in great depth. So most of our patients who have hepatitis are asymptomatic. Around 70 to 80% are asymptomatic. So if they don't go for their blood test, they would not know that they have evidence of liver disease. Of course, 20 to 30% present late, and these are the ones that we can see who comes in with jaundice. Other signs of chronic liver disease would be pulmonary erythema, finger clubbing, gynecomastia, ascites, splenomegaly, peripheral edema. So hepatic decompensation, which I meant is defined by ascites, water accumulation in the abdomen, hepatic encephalopathy, when they come in with confusion, portal hypertensive, in other words, they come in with upper GI bleed. So ascites is commonly the first decompensation defining event. And when they have this, with 5 to 10% of them, which compensated develop over
The recording has stopped.
per year, and the
This
development
meeting is being recorded.
associated with reduction in 5-year survival from 80 to 30%. So what's the pathogenesis of liver cirrhosis? So it all starts with arterial underfilling. If you can understand that the cirrhosis, the liver is hardened and fibrosis, so this will lead to splenic vasodilation. And with evidence of splenic vasodilation, there will all this hormonal activation of the vasoconstrictors and your antidiuretic factors starts to happen, and this will lead to sodium retention and plasma volume expansion. With cirrhosis as well, you can lead to portal hypertension, increase in sinusoidal pressure, lymphatic formations, and the ascites formation. So if you want to look at it more clearly, you can at least say that in cirrhosis, the complications happen when there's evidence of portal hypertension, such as variceal hemorrhage, ascites, and when one gets ascites, it will lead to spontaneous bacterial peritonitis or hepatorenal syndrome. And with liver insufficiency, things like jaundice and encephalopathy can happen. So let's talk about ascites. So when ascites formation, so this is water accumulation in your peritoneal cavity, or what the Malays would call it as busung. So when you have liver disease, the protein cannot be metabolized, it's reduced blood albumin, therefore reduced in colloid osmotic pressure, and therefore the fluid leakage from the blood vessels. Or if you have portal hypertension and increase in hydrostatic pressure, with the fluid leakage from the blood vessels, there'll be a build-up of water in the peritoneal cavity, and you can actually see like this big distended abdomen. They look like they're pregnant or something, besar. So what can we do when patients develop ascites? So again, this is when what we need, your help, a formal consultation with our dietitian helps. They come in and help us actually preparing the patient's diet. So what we need from them is actually to let our patients have moderate dietary sodium restriction. That means 2 grams or 90 millimoles per day. So if the patient so they have to spread it from morning, lunch, and dinner time. And it should be prescribed to achieve a negative sodium balance and net fluid loss. You need to understand as well that fluid restriction is not indicated unless there's evidence of hyponatremia. So what I mean by hyponatremia is sodium below 135, mild hyponatremia, 125 to 135, you can do without, but if it's 125 and below, you may want to have fluid restriction. So otherwise, you can have as much as fluid as possible. So you may want to monitor this patient with daily monitoring of body weight. And if the patients have peripheral edema, we aim to lose around 0.5 kilograms per day. And with peripheral edema, around 1 kilogram per day. So sometimes this patient with repeated, or if the liver is too cirrhotic, they have refractory ascites. So this occurs approximately in 5 to 10% of all patients with cirrhosis. And once it has set in, there is poor survival, around 50% at 6 months. Refractory ascites is defined when ascites that cannot be mobilized or recur even after large volume paracentesis despite dietary sodium restriction and diuretic therapy. So refractory ascites can be further divided into diuretic resistance. That means they even have persistent ascites despite maximal dose of diuretics, or the diuretic intractable, in which the side effects of diuretics preclude the use of maximum doses. We are well aware that the diuretics that we use are the spironolactone, which can lead to painful gynecomastia. And we also use loop diuretics, furosemide, and we know they can cause muscle cramps and electrolyte imbalance. So just looking at the medications, the drug that we use for treatment of ascites, refractory ascites, would be the aldosterone antagonist, mainly the spironolactone, potassium sparing agent. Look out for your electrolytes when you're on your spironolactone, and look out for the side effects, painful gynecomastia, and loop diuretics, may it be furosemide and bumetanide. And just a note that our spironolactone furosemide works well synergistically, and the ratio that we use for our medication will be 2.5 to 1. Of course, in patients who we cannot achieve ascites prevention with salt restriction and ascites and diuretics, they need to come in regularly for large volume paracentesis. So these are the areas that our doctors would actually puncture to take out the ascites fluid 2 centimeters below the umbilical or 2 centimeters medial to the anterior superior iliac spine, and we can drain as much as 5 to 8 liters a day, or even maximum is the blood pressure is permeable, and if we want to drain more than 5 liters, we need to replace back with albumin. Now let's start with varicose bleed. So this is our splenic circulation, the circulation from your blood supply from the stomach, spleen, pancreas, intestines, via the portal vein to the liver, through the sinusoids, and again from splenic circulation to the liver as well. And this will lead to inferior vena cava to the heart. So what happens with portal hypertension? Because the liver is cirrhotic, hard and hardened, there is increased resistance within the hepatocytes, within the liver. So the blood supply is unable to cut across towards the liver to get to your heart, and therefore it opens other collateral circulation. There is a diversion of the portal blood into the systemic vein via the azygous vein, and of course the formation of varicose at your esophagus. So we can see here, portal hypertension is defined when there's an increase in portal pressure, in which the portal pressure and the inferior vena cava, the pressure gradient between the two, is increased above normal limits of 5 millimeters mercury. The normal pressure will be around 3 to 6. More than 10 millimeters mercury, there'll be formation of varices. More than 12 millimeter mercury is a threshold for variceal rupture and ascites. So if you can appreciate, when the pressure across these two is high, more than 5, there'll be formation of varices because the blood can't go across the liver because it's hardened, and this formation of varices. And when the pressure is more than 12, it will burst and the patient will come in with upper GI bleed. So if you actually do an endoscopy, you can see this blood engorged vessels as you look down the esophagus. And when we see that, when we see areas that's about to burst, cherry red spots, or if it bleeds, you may want to apply banding during our endoscopic procedure. So let's talk about encephalopathy. So when does a patient develop encephalopathy? So you know all the proteins, all the food that we take in are degraded into ammonia, and ammonia will be by the liver and the kidney. But if the liver is damaged, so the ammonia will accumulate in the blood system. It can cross the blood-brain barrier. It will be converted to glutamine in the astrocytes, causing intracellular swelling and edema. So in hepatic encephalopathy, again, where the patient presents with confusion, they come in, there's evidence of nitrogen waste, ammonia cannot be broken down, and which accumulated into ammonia in the blood and toxin to the brain. So there's lots of precipitating factors when there is upper GI bleed or increased protein, evidence of electrolytes imbalance, low sodium, low sugar, when there's infection on board, when there is a patient is dehydrated, or even certain drugs that we give to these patients, mainly sedatives and antidepressant, can lead to encephalopathy. So again, when you see these patients, we tend to ensure that to treat the underlying cause. If infection was a reason, we will treat them with antibiotics. And if it's constipation is the cause, we want to give them with some electrolytes. look. So the clinical presentation of encephalopathy are divided into grades. Very is of sleep pattern. This more in the morning as opposed to the evening. Grade 1 will be a bit of shortened attention span. Develop this asterisk would be when they have an obvious personality change. Grade 3 would be solemn took through you. So this is what you see when I mentioned flapping tremors. You just ask them to stretch out your hands outside, and you can see this little flap that they do. And of course, when you try to talk to them, they are disorientated, time, place, and person, and they are unable to answer your questions. So again, if encephalopathy was a cause, look for the underlying precipitating factors and treat them. Of course, there's lactulose, which is widely used as a non-absorbable disaccharide, which is recommended for hepatic encephalopathy. Again, this lactulose are not broken down in the small intestine, but mainly in the large intestine. Besides the cathartic effect, excretion of the sodium, and it's also good in prevention of encephalopathy. What about nutrition? Of course, you know, sarcopenia in our most of our patients, and protein use and the branching amino acid. But I will not steal the limelight from Aisha later. I think she's going to cover all this. So in our patients, it's very important. You lot are very important person to help us manage our patients, because when we see a patient with liver cirrhosis, we will tend to grade them according to the Charles-Pugh score. If you actually been to our ward or look through a patient with a liver cirrhosis, you would see the notes, the doctor's notes, they talk about Charles-Pugh score or MELT score. So Charles-Pugh score is just accumulating these little marks that we get from 5 variables, mainly 2 clinical variables, which are ascites and encephalopathy, and 3 biochemical variables, which is the albumin, bilirubin, and prothrombin time. If you can actually look at it, bilirubin prolongation less than 2 gives you a mark, 2 to 3 gives you 2 marks, more than 3 gives you 3 marks, albumin more than 35 give you 1 mark, 28 to 35 gives you 2 marks, less than 28 gives you 3 marks, and you can see same thing with INR over here, 1.7, 1.7 to 2.3, and more than 2.3, ascites non-moderate and severe. If the patients do not have ascites, but they're on diuretics, it's considered as 2 marks as well, and encephalopathy non-minimal and advanced. And when you start to add them up together, wherever they are, 1, 2, 3, 4, 5, 6 or something, you can tell them whether they are Charles A, B, or C. A total addition of 5 to 6 is with Charles A, 7 to 9 is B, and Charles C is 10 to 15. And you can see from here that the higher the number, the worse the patient is. That means Charles C is worse than Charles A. Besides using the Charles-Pugh score in our patients, there's also the MELT score that we always used. It's a mathematical model. You can see the formula there, but the easier way out is to have it calculated on your QX calculator. And it's actually a reliable measure of mortality risk in patients with end-stage liver disease. It's also used as a disease severity index to help prioritize allocation of organs for transplant. So just 2 or 3 more notes about transplantation. When the patients have end-stage liver cirrhosis, when they have complications, may it be ascites, recurrent ascites, or encephalopathy, or upper GI bleed, which are unable to be managed with medical treatment, we can actually offer the patient on liver transplantation. And within our setting, liver transplant is done mainly in Hospital Selayang. We do living donation and cadaveric donation. University Malaya does cadaveric living related as well. And the Women and Child Hospital does pediatric patients. So you can see here, the liver transplant can be given a living donation where they give half of the liver, the right lobe or the left lobe, or a bit of the segment if it's a pediatric patient, or in a brain death patient, cadaveric donation, giving the whole lot, the whole liver graft to the recipient. So just cadaveric transplant, you can remove your cirrhotic diseased liver and put in the new liver, or in living related liver transplant, the donor give half a portion of the liver to the recipient. And that's the recipient's diseased liver being removed. So just to share our experience about liver transplant, we started in 2002. Last year was good. There was like 20 transplants been done. Of course, this year, because of MCO, we had to be stopped, but we are picking up slowly but surely. So in summary, liver is an important organ. There's complications of liver cirrhosis, which is ascites, variceal bleed, encephalopathy can lead to high mortality. Liver transplantation can be considered in patients with end-stage liver disease. Again, the treatment of liver cirrhosis, liver disease, there are all this multidisciplinary approach. It involves the doctors, the nurses, the pharmacists, the dietitians, and the physiotherapists. With that, I thank you, and I can take any questions if there are. Thank you. Is there any questions? I can't hear any. I'm not so sure whether you're all muted and you can't ask me. Can be done among family members. Doctor, liver transplantation can be done among family members, right? In your experience, is there many donors among family members? Yes, when there is an acute liver failure, that means the patient is not cirrhotic. When suddenly, because of certain drugs or hepatitis B flare, the liver failed. So we call it acute liver failure. And when they have an acute liver failure, there's not much window period for cadaveric donors. Hence, the family members will ask among the family members, but it have to be first degree relatives. That means it'll be your spouse, your parents, your siblings, or your children. Hopefully, the liver donor would be someone young, around 50 years or so and below, non-smoker, non-drinker, and does not have hyperlipidemia for us to use your liver. If you can see around most of us or most of our patients have probably fatty liver disease as well, and that's be a bit difficult for us to do liver transplant. Thanks, Dr. Ahmad. Encik Ahmad, hi, Dr. Haniza. I know how it depends on if they have any complications. You know, when you have a transplant, you need to be on high dose of immunosuppression at the initial base, the initial part, and you will see whether these patients develop infection on board because they're on high dose steroids, or they are too sarcopenic and therefore there's not much muscle for them to be able to recuperate as fast as before. But usually we will think around 2 to 4 weeks they should be up, and we usually tell them if they're working, they need to be on leave at least 3 to 6 months. They have to be staying at home, and the initial bit, they can't go out in crowded places. They probably have to do what we're doing now, all this mask and face shield, hair hygiene, and once the immunosuppression are tapered down, they should be able to live as normal. We do the transplant so they can lead a normal life, have a family. So we do have patients who was transplanted and later on got married and have children. Oh, it's all on transplant. Do you know, Doctor, would you explain a little bit, decide how big of the liver portion needed to be transplanted? So if it's a cadaveric liver, that means a brain death liver, we take the whole bit of the liver, to the patient. If it's living related, yes, the donor, the person who's giving the liver, has to be going through certain assessment as well. We have to make sure that their cardiac status, their lungs, their CT, there's no anatomical variation in their anatomy of the liver, the portal vein, the hepatic artery, and the hepatic vein. And then the radiologist will actually calculate and see. We have to see the size. First, we have to have blood group compatibility. A B goes to a B, and A goes to an A. O is a universal donor. It can be given to any of those blood groups. So you must see the size of the donor and the recipient. Hopefully, they're more or less the same size. So if a person, if the patient is like as big as me, 60 kilos, or somehow I can't have a 30 kilo child giving the liver, half the liver to me naturally. So the radiologist has to mark the areas and see if they take the right lobe of the donor's liver for the recipient, whether what is left on the donor is sufficient for them. Any reason that they can't, they won't, it will not be a go. How you explain a bit on this, how big a liver function? Okay, hi Hidayah, how much is the incidence of liver transplant rejection? So I would think at least 1/3 to half the patients post-transplant would have some complication, may it be infection or biliary leakage or rejection. But don't worry if there's a rejection. If we catch them early with blood tests, we should be able to treat them with higher dose of steroids. Steroids is an immunosuppression. So you will also notice the side effects of using high dose steroids. That is diabetes mellitus, more prone to infection and so forth. Is there any complications for donor? Well, for a donor, they are healthy people. They do not need the transplant. So sometimes if you look at it, the risk for the donor is there. For someone who's well and does not need any surgery, you are putting them to be under anesthesia and under surgery. But most of the time they do well. Of course, the normal surgical complication of a hepatectomy, that means taking part of your liver, will be again a bit of infection, a bit of biliary leak, but they do well after that. By a week or so, they should be up of their feet. So one more question for me, if I may. Of course, you may. If patient is already at end stage disease, it's not an active management, does nutrition really help to improve? Of course, it does. Nutrition always helps in the patient. Help. We do not have other options. Is there any other questions that I may take?
Dr. Haniza, there is one more question.
Yeah.
Mostly patients with liver cirrhosis were referred to dietitian for low salt diet. But as mentioned earlier in your talk, patient is actually need moderate sodium. So what was the question?
What was the question? What's the answer?
So what was the answer?
Right. So when I talk about low salt diet, when they develop ascites, we're not talking about. I mean, if you are in from our hospital, if the wards are filled with other cases, pancreatitis, no, I do not need them to be salt restrict. Once they start develop ascites, I need them to be on salt restriction, which is the 2 grams or half a teaspoon for the whole day, 90 millimoles per day. Okay, so there's no restriction in water. As I said, they can drink as many as they want, but sometimes the things that they buy, the bottled drinks, you may want to check all the ikan masin or the food that they take, the drinks that they have high salt content or not. Okay, so sometimes this patient has hyponatremia as well, low sodium. So in this in these patients, you may want to see why is the salt low. Is it because they are hypovolemic, they were vomiting out blood, or they're having diarrhea, or is it the diuretics has caused them, or it's just normal volume? So it may, in those cases, perhaps where the sodium is too low, when the sodium is below 125 or 120 more of at least, it can cause cerebral damage. So in that sort of patients, maybe we do allow some sodium to be given to this patient. But generally, salt restriction, half a teaspoon for the whole day. But even if the ascites accumulate, it's no salt at all. So generally, I'm not going to curi Aisha's talk, but generally we tell them they have to substitute salt with something else, maybe pepper. I don't say lada. Lada to some is chili, chili, pepper or chili or lime. All these other methods to entice them to take food. Because if it's tasteless and bland, they will not be able to take this food. And if they don't take the food, the muscles are not going to go, and it's such a vicious cycle. Okay.
All right.
All
Is
right.
there
Yes,
any
I
more
answer your
question? If there is no question, I have a question for you, Dr. Haniza.
Sure.
Okay, in your opinion, would you recommend healthcare workers for hepatitis screening, like dietitian or pharmacists? And how often should we do it?
You're talking about hepatitis B, I presume?
Yes.
Okay. So, anybody who works in hospital, I would think they need to be screened for viral hepatitis. I'm talking about viral hepatitis, mainly B and C. Why? Because it can lead to chronicity, it can lead to cirrhosis. Again, if you're working in our ward, most of our patients have hepatitis B and C, and the transmission of viral hepatitis is blood to blood. So I would always suggest that these doctors or nurses or paramedics working in my ward to check their hepatitis B status and get vaccinated, get a booster if your antibody levels are low.
And then how often should?
How often? So if you don't have hepatitis, well, it depends on whether you're exposed or you have a risk factor or you suddenly got a needle prick injury in the ward. So that's the time when you need to do it. How often is always case to case basis, depends where you work for, whether your pathologist is happy to have 160 or 200 people sending their viral hepatitis B every 6 months or so. But if you have already known that you have hepatitis B, you don't have hepatitis B and you already got yourself vaccinated, at least keep your antibody levels at any number, maybe more than 100 if you're living with someone with hepatitis B, or even more than 10, because we have a memory cells in our body that in case we get a needle prick injury or exposed to a blood which has hepatitis B, it will actually mount a response. So I'm not answering your question actually. Usually, suffice to say once a year is good enough if your pathologist, if your lab can afford it.
All right. Okay, one question from the participant. Hi, doctor. May I know your opinion on restriction of protein for stage 5 hepatic NCAF?
Okay. I don't really restrict much protein. I know you're talking about the more protein can cause lots of nitrogen, encephalopathy, but actually there's grade 1, 2, 3, and 4. Only 4 is really the worst. So the grade 4 encephalopathy will be comatose patient. So I don't actually restrict proteins on my patient actually.
All right. Okay. Is there any question from the participant? I think maybe one last question from me.
Yes, okay.
How can we prevent hepatitis A transmission from food? As now we heavily relied on food delivery and eating out. So how can we prevent that?
Hepatitis A is fecal oral, as we said it. So it's mainly by food. So you have to ensure that you eat at the right, nice place. Because it's fecal oral, it's mainly in seashells, all the kerangs, and yes, you can eat it, no doubt. So you have to make sure that it's well cooked. It's not just on those Sedap je goreng-goreng. There, that's your char kway teow with kerang, you know. So, and you have to see which kedai mamak that you eat lah. So, if you like to eat char kway teow with kerang and you can't say no to it, you should get yourself vaccinated for hepatitis A. Hepatitis A vaccination is 2 at 0 month and 6 months. Hepatitis B is 0, 1, and 6 months. It's 3 doses and 2 doses. So hepatitis A, once you get yourself vaccinated, it should last you for around 2 years or so. And if you are being protected from hepatitis A, you can eat all the sushis and all the char kway teows that you like. Hepatitis A does not become chronic, not like hepatitis B or hepatitis C, so you should be grand.
All right. I think there is no more question. So once again, thank you, Dr. Haniza, for answering the burning question from audience. And huge thank you for a very informative talk. It was a pleasure having you with us today. Thank you very much, Doctor.
All right.
Bye.
Thank you. Bye-bye.
Bye.
See you then. Bye.
All right. Okay, now let's invite our next speaker to talk about MNT for liver cirrhosis. So we have with us today Puan Aisyah Hanum binti Muhammad Said. She is a clinical dietitian from Hospital Selayang. She graduated from University Putra Malaysia with a Bachelor in Dietetics in 2016 and also in Diploma of Pharmacy from University Technology Mara Pulau Pinang in 2012. She has been working as clinical dietitian since 2017 and currently practicing medical nutrition therapy in hepatology, gastroenterology, and hepatobiliary that cover inpatients and outpatient specialized clinic. She's a firm believer that nutrition is the key ingredient to a healthy and a better quality of life. So please welcome Puan Aisyah.
Thank you, Puan Fadilatul, for the very kind introduction. Wait, I'll share my screen. So can everyone see? Okay, right. So Assalamualaikum warahmatullahi wabarakatuh and a very good afternoon to everyone. My name is Aisyah Hanu binti Muhammad Said. So basically I am one of the dietitians here in Hospital Selayang. So today I will share a little bit on the topic of medical nutrition therapy on liver cirrhosis and basically how we actually manage patient liver cirrhosis in our ward lah. So this is the outline of my presentation and I will start my presentation with introduction. So I think everyone know that a person cannot live or cannot survive without a liver. So liver is important for both body digestion and also metabolism. So a person with advanced liver disease is basically at risk of malnutrition. So malnutrition is a serious complication of liver disease and is often associated with worse outcome and commonly seen among these liver cirrhosis patients. So malnutrition in liver cirrhosis. Basically, the etiology of malnutrition among these liver cirrhosis is very multifactorial. Malnutrition is commonly seen around 20 to 60% of patients with liver cirrhosis, and it is often associated with increased risk of mortality, higher prevalence of portal hypertension-related complications, increased risk of infection, and also longer stays in the hospital. Okay, some factors that contribute to malnutrition among these liver cirrhosis patients. The first one would be inadequate oral intake. So which is mainly contributed by early satiety, nausea and vomiting and also restricted diet. The second one would be malabsorption. The third one would be altered metabolism. And the last one would be increased nutrient demands. So we will discuss more on these factors. So the first one would be inadequate oral intake. This is the most common reason that actually leads to malnutrition among these liver cirrhosis patients. Mainly contributed when most patients complain of early satiety because of the presence of ascites, nausea and vomiting, and also due to restricted diet, which means most of these patients that comes with fluid retention will need to be put on low salt diet. So long term of low salt diet, making these patients to have reduced oral intake because food are unpalatable. Okay, So what we, us as a dietitian need to do, we need to provide them with oral nutrition supplement or even enteral feeding, so that they can achieve their energy and also protein requirement daily. So the next factor is actually malabsorption. So we can usually see fat malabsorption is common among these liver cirrhosis patients, mainly due to the shortage or absence of bile, and can be seen if patient has reported to have steatoria, and this is need to be treated to prevent fat soluble vitamins, vitamin A, D, E, K. Thus, what we need to do is to provide them with supplementations lah. Other than that, chronic use of lactulose also can cause nutrient malabsorption. The third factor is altered metabolism. So we can see that there will be altered fat, protein, and also carbohydrate metabolism. Chronic alcohol consumptions among these liver cirrhosis patients can actually leads to altered fatty acid metabolism. For protein metabolism, can happen due to increased protein catabolism and reduced protein synthesis. And eventually, this can cause a decrease in serum branch change amino acid level (BCAA) and imbalance of between BCAA and also aromatic amino acid. For carbohydrate metabolism, can be altered also, which can cause by insulin resistance and also the promotion of gluconeogenesis. So the last factor that can contribute to malnutrition is actually increased nutrient demands. Increased energy expenditure can lead to malnutrition because around 15 to 30% of cirrhotic patients are basically hypermetabolic. With increased resting energy expenditure, they can up to 120%. This will actually negatively affect patients' nutrition status. Cirrhotic patient who is also having inflammation at the same time, okay, is mostly affected because inflammation basically will promote hypermetabolic state. And frequent peritoneal tapping also, or paracentesis of tapping in very large amount also can cause increased nutrient demands, mainly due to protein losses. So we move on to the nutritional issues in liver cirrhosis patient. What we actually need to frequently assess among these liver cirrhosis patient, there is 4 parameters. The first one would be weight and body composition changes. So we need to assess if patient presented with muscle loss. Okay, muscle loss basically is more prominent in men than women because we as a woman usually have more fat stores as compared to a man, and we need to frequently assess and evaluate their weight changes. And while estimating patient weight, try to use dry weight as much as possible. So the next parameter would be dietary intake. So we need to assess patient diet history, including their portion size, nutrient content, or even fluid intake, and need to identify what are the barriers that can impact patient dietary intake. Some of them could be altered taste. Does patient have very unpalatable food because of the low sodium diet and also early satiety in patient with ascites. The next parameter is GI symptoms. Okay, GI symptoms, what we need to assess is, are they having or experiencing nausea, vomiting, or even diarrhea? Because these losses, GI losses, can actually affect both nutritional and fluid status. And the last one would be excretion. Most of these liver cirrhosis patients will have hyponatremia and also water retention. So due to the inability of the kidney to handle water and the usage of antidiuretic hormone. Next one, it would be nutrition screening tools. Okay. Previously, subjective global assessment or SGA is commonly used by us, the dietitian, to screen patients if they are at risk of malnutrition. Okay, but now current guidelines has shown that the Royal Free Hospital Nutrition Prioritizing Tool, RHNPT, is one of the most recommended tool to be used to screen if patient is at risk of malnutrition among these liver cirrhosis patient. Okay, so it has higher sensitivity and specificity as compared to other tools. It includes 3 major steps. and has 5 measurements, including BMI, unplanned weight loss, dietary intake, severity of hepatitis, and also interference with food intake by current complication. Either patient is having ascites or general fluid overload. So when we have computed the scores, okay, the patient will be classified either being low risk, moderate risk, or even high risk of malnutrition. So for physical examination, what we need to examine patient among these liver cirrhosis patient, first one, does patient comes with ascites? Some patient we can see easily they are having ascites which with bulging abdomen, and some patient need to do we need to find out if they are having ascites by undergoing ultrasound. The second one is edema. Does patient comes with pedal edema, ankle, or even sacral? Fat loss, okay, around eyes, tricep, and ribs. And last one would be muscle wasting. Okay, we move on to the micronutrient deficiencies among this liver disease patient. So, commonly seen micronutrient deficiency among this liver cirrhosis patient because of high incidence of GI losses study lah. Okay, so we can see most of these patients will have vitamin A deficiency, thiamine, niacin, pyridoxine, cyanocobalamin, zinc, magnesium, folate, ascorbic acid, and also vitamin K. So we need to provide patient with vitamin supplementation. Next one would be the BCAA supplementation. BCAA, or branch chain amino acid, is actually defined as essential amino acid, including valine, leucine, and also isoleucine. They are metabolized by the body and used as a source of muscle energy. So basically, BCAA will help to prevent lipolysis and also proteolysis and improve nitrogen balance, muscle mass, nutritional status, complication-free survival, quality of life, and also hepatocellular carcinoma risk. BCAA also can help in balancing between amino acid ratio between BCAA and also aromatic amino acid, because excess aromatic amino acid can lead to the occurrence of hepatic and CAF. So this is mainly because of the accumulation of body waste, either ammonia or amine inside the body lah. So for late evening snack, so it is important to prescribe patient with late evening snack or LES to shorten the overnight fasting period. So there are some benefit of prescribing late evening snack. So the first one would be decrease lipid oxidation, will help to improve patient's nitrogen balance, decrease skeletal muscle protein breakdown overnight, and also will minimize patient gluconeogenesis and also preserve muscle mass. Okay, there are various studies that suggesting how much carbohydrate that needed to be prescribed to patient. So mainly 50 gram of carbohydrate is the minimal amount needed, equal to almost 3 to 3.5 exchange of carbo needed to be taken before they are going to bed. Okay, just to prevent the ketogenesis and also nitrogen sparing effect. In compensated cirrhosis patient that is not presented with any other sign and symptom of cirrhosis, okay, late evening snack also should be advised to them to preserve their existing skeletal muscle mass. Okay, now we'll share with you guys on this one case study on liver cirrhosis. Okay, for client history, the first visit was on 5th of May. Patient was Miss K, 52 years old Indian lady. She is a housewife and used to work as a cleaner. She is married and blessed with 3 children. She was diagnosed with decompensated liver cirrhosis secondary to chronic hep C. So she came with a Child-Pugh score of C and also MELD score of 20. And she has underlying chronic hep C and also iron deficiency anemia. So the reason of referral for patient to dietitian is for high protein and also low salt diet. So for anthropometric measurement, during the first visit, basically patient has weight 58 kg with the height of 1.5, and this will contribute to BMI of 25.77. Usually for normal people, we will consider patient as overweight, but patient presented with severe ascites. So usually we won't count this weight and patient is not categorized as overweight. So we will use patient dry weight, and this can be done by based on the patient's severity of ascites. How to calculate? We can estimate patient dry weight by using this table, okay, by Medenhall 1992. So if patient currently presented with severe ascites, so there is mild, moderate, and also severe. So 14 kg, and patient also actually presented with mild pedal edema. So from 58 kg, patient current weight, we will minus 14 from ascites and also 1 kg from edema. So the dry weight of patient would be 43 kg. So this is the biochemical data of patient during the first visit. Patient come with low HB, low albumin, and also elevated ALT, AST, and also high bilirubin. So for CT finding, have found out that it is confirmed that patient has liver cirrhosis with portal hypertension. For nutrition focused physical finding, so patient appear to have severe ascites. On the day of first visit, patient has BO 2 times. Claim that she has a reduced appetite and has been loss of appetite since past 1 week. Complaint of early satiety, patient appears to be jaundice, had mild PD edema, the IO of negative 4,000. This is mainly because patient has done peritoneal tapping that has drained 4 liter of ascitic fluid. And at that time, I have done SGA and patient has score C, and RFNPT also patient has score patient is considered as high risk of malnutrition with score of 6. Bear in mind, every 1 liter of drain among this patient with liver cirrhosis, every 1 liter of peritoneal tapping is equal to 13 kg of protein loss. So we need to replace them with 50 ml of IV albumin every 1 liter of ascitic fluid drain. We move on to the nutrition related history. I've done a 24-hour diet recall to this patient. So the estimated energy intake is around 900 kilocalorie, which is contribute to 50% of patient's energy requirement. And the protein is contribute around 31 gram, which is 48% of protein requirement. As food checklist, macam tadi, patient has reduced oral intake, complaint of reduced oral intake since past 1 week, and most of these liver cirrhosis patient, they always know that they need to practice low salt diet in their daily life because of the fluid retention that they have. Okay, we move on to the comparative standard. So I use Aspen guideline when we want to prescribe energy or protein or even BCAA requirement. But bear in mind, indirect calorimetry is always the gold standard when prescribing energy needs for patient. For this patient, so she is a decompensated liver cirrhosis. So the energy requirement will be 35 to 40 kilocalorie per kg. For compensated liver cirrhosis would be 30 to 35 kg per day. For protein requirement, for decompensated, around 1.2 to 1.5 kg per day, and compensated liver cirrhosis would be around 1.2 gram per kg per day. For hepatic and calf, it is not advisable to reduce protein intake, and actually protein can go up until 1.8 gram per kg body weight. For BCAA requirement, the recommendation would be 0.25 gram per kg body weight per day. So for nutrition diagnosis, On this first visit, it will be inadequate protein energy intake related to change in appetite due to physiological causes as evidenced by patient verbalization. Energy intake only achieve 52% of requirement and with the presence of SITs and low HB and also albumin level. So for nutrition intervention, my short-term goals would be to improve patient oral intake. Okay, and the other one would be to improve patients' biochemical data and also sign and symptom. And we also try to have or set a long-term goal for this liver cirrhosis patient is to prevent malnutrition among them and also to improve patients' quality of life. So my nutrition prescription will be using the dosing weight of 43, which is patient's dry weight that we have calculated earlier. So energy prescription would be around 1,005 to 1,007 with protein 52 to 64 gram per day and BCAA would be 10.8 gram per day. So my plan, first one, we always encourage patients to eat as much as they can tolerate, and suggest them to have small and frequent meals. Basically, try to have 3 main meals with 2 snacks and also 1 late evening snack. And also supplement the patient with oral nutrition supplement. And we using the BCAA supplement that is available in the hospital. Okay, 2 times per day, and this will contribute around 24% of patient energy requirement, 42% of protein requirement, and also the BCAA provided is 12.2 grams per day. And always emphasize on to patient that they need to be on high protein diet and also low fat diet. For the ONS just now, I do suggest patient to take around 10 a.m. and also pre-bed. This is will be considered as a snack. Okay, so as mentioned before, the BCAA for patient is needed around 10.8 gram per day. So why we give BCAA? Because it can lead to positive nutrient balance and also improve hepatic NCAF. For long term, will improve liver function and also nutritional status. So basically, for this patient, 10.8 gram, patient require around 2 serving of BCAA supplementation per day, because 1 serving of BCAA supplement will provide around 6.1 gram of BCAA. So NME, next visit shall monitor again patient's diet intake, biochemical data, and also ascites severity. So on the second visit, on the first follow-up, the next day, so patient's biochemical data, there's not much changes. The HB is getting a little bit lower, around 10.5. Still remain low albumin and elevated ALT, AST, and also bilirubin. For nutrition focused physical finding, even though patient has been tapping and drained 4 liters of ascitic fluid, still the ascites can be considered as severe. Okay, patient has BO 3 times and still complain having appetite low, still complain of early satiety, appears jaundice, and the IO would be negative 2060. And during the second visit, patient also has done another peritoneal tapping, which drained around 3 liters ascitic fluid. From basically, I've seen a few patients that done until 8 liters of peritoneal tapping done in one day. That is very, very high amount of protein losses at one time. Okay. For food and nutrition related history, I have spoken to patient. She claimed that she's able to finish half of the food served and try her best to finish the protein food served. But on the second visit, patient did complain that she unable to tolerate the BCAA supplement provided to patient, mainly because this supplement is actually very unpalatable to be drink. Okay, so she has taken only one time and refused to take more. So during this second visit, the estimated energy intake would be around 70% and the protein intake is around 69%. Okay, for the nutrition diagnosis, there shows a improvement from the first visit to the second visit. So my plan still the same. Encourage orally as tolerated, and suggesting three main meals with two snack and also one late evening snack. But for the oral nutrition supplement, I have changed the supplement to a standard formula with addition of protein modular, and we will give around 3 times a day. This will contribute around 30 grams of 30% of energy and also 51% of protein requirement. So I've suggested patient to take around 10 a.m., 3 p.m. and also during pre-bed. So the next one would be the second follow-up, the third visit, which is the last visit. Patient nutrition focused physical findings. Sorry, this still patient appear to be in severe ascites, had BO 3 times, but did claim has improved appetite after being tapping 2 times. And on the day of patients on the third visit, there's no tapping done on that day. Okay. For food and nutrition related history, patients claim that still able to finish half of the food served in ward, but happily mentioned that she able to finish the protein food stuff during lunch yesterday, and also claimed that she tolerating the ONS prescribed with the standard formula given yesterday 3 times. And I've noted also patient is planned to discharge on the evening of the day of visit. So basically, most of these liver patient will come 3 weekly to the ward for peritoneal tapping only. Sometimes they come in the morning, then will be discharged in the afternoon just for tapping. So the admission rate is very high lah. Okay. So for this third visit, the estimated energy intake is around 82%, and the estimated protein intake is around 100%. It's achieved 100% lah. So what I've planned to continue previous plan, okay, and always remind patient if they can afford, try to continue the oral nutrition supplement at home, especially on the pre-bed ONS, and always re-emphasize back on the high protein and low salt diet that they need to practice daily. Okay, this is just one interesting table that I found that it's actually a summary of dietary recommendation in cirrhosis patient. Okay, this has already concluded what we need to do, how much we can prescribe, and how much we can give to patient that is with cirrhosis. And this is also a summary of recommendation for oral nutrition supplement, micronutrient supplementation, and also branch chain amino acid supplementation that can be given to patient with liver cirrhosis. So I've come to the conclusion. So we as a dietitian, our role as a dietitian, we need to help to identify patient who is at risk of malnutrition, because mainly patient comes with liver cirrhosis are at risk of malnutrition, and there is a high prevalence of protein energy malnutrition among these liver patients. So malnutrition should be identified and treated early. Nutrition support can and does improve patient morbidity and mortality. Nutrition intervention that we prescribe to patient must tailor with patient needs, and close monitoring and regular monitoring is essential, and dietary restrictions are rarely indicated for this liver cirrhosis patient. And that's all from me. Thank you.
All right. Thank you, Puan Aisha, for the interesting and very informative talk. So now let's proceed to the Q&A session. Okay, there is a lot of question here. So I'll read one by one. Okay, the first question is from Ahmad Shakirin. How do you measure dry weight as these patients are having retention, ascites, and edema? I think this one you had shared just now, right?
Yeah. So on the early slide, on the earlier part of the nutrition, my case study, right? Okay, there's you have to minus if the patient, usually a patient. Okay, then we will see the
This
progress and
meeting is
also
being
always monitor
recorded.
patient liver, renal profile. If there's no too much derange in renal profile, then we can step up dia punya protein intake tu, protein requirement tu bit by bit lah. Can up to 1.2 actually, tak ada masalah. Because patient punya requirement sangat tinggi when they have decompensated liver cirrhosis.
Okay, next question. Oh, this one, can you show back the slide on how to calculate dry weight for patient with ascites and edema? She want to see the reference, the Madden
Okay.
Hall just now, right?
Okay, sekejap I share balik. Share screen. Okay. So the Madden Hall would be, okay, this one. Okay. So how we can actually determine patient punya dry weight lah. Okay. Usually saya pakai this table sahaja. But some patients, they orang memang obese. Ada juga yang macam tu. Okay, if patient are overweight or obese, kita this table tak boleh guna. Okay, because we might give patient will be tend to have overnutrition lah. Kita might prescribe excess energy dekat patient. So apa yang saya buat usually is we will prescribe patient using IBW of 22.5 if they are overweight or obese. It comes with ascites. Yes. Menjawab ke? Okay, right?
Okay. Okay. The next question, for late evening snack, how much of carbohydrate would you plan for a cirrhosis patient with underlying DM?
Okay, this is one tricky part lah. Okay, memang the recommendation would be 50 gram minimal. Tapi yes, we have to always count the carbohydrate requirement for patient kan among this diabetic patient. So usually can up to only 2 exchange for late evening snacks. Itu saja. Okay.
Okay, so 2 exchange lah.
Yeah, 2 exchange. 1 to 2 exchange for diabetic patient lah. And if ada diabetic formula, sebenarnya lebih baik.
Okay. So may I know what type of BCAA supplement do you use?
Okay, dekat Malaysia, as far as I know, we have only one, which is the aminoleban. We only have aminoleban here in Hospital Selayang. So that is the BCAA supplementation that we use here lah.
Okay, so that answered the next question. We only use aminoleban. Is there any others? No lah.
No.
Okay.
Okay.
Okay, next question. May I know if there is no BCAA supplement available in current hospital, how to substitute the BCAA, or is there any alternative substitution?
Okay, so BCAA, actually you can find naturally in fish, plant sources protein. Okay, you can actually prescribe patient or tell patient that despite taking protein from animal sources, you can also add in extra protein from plant-based sources macam tahu ke, tempe ke, okay, even susu pun ada a very good amount of BCAA juga. Okay, so kiranya kalau kita nak prescribe protein, they may have like one serving of protein macam ayam, then extra plant sources protein juga. Macam tu. Kalau tak ada BCAA supplement lah, boleh juga kita buat macam tu.
Okay.
Okay. Alright.
Is it a practice to replace protein losses from peritoneal drain?
Yes. Here in Selayang, patient with peritoneal tapping will always be replaced with IV albumin.
They are giving human albumin.
Yeah, human albumin.
Okay. Okay, next question. Do you advise if patient take BCAA supplement from modular formula as those taken in sport? Cause the some product I know have some fruity flavor.
Usually, we won't advise patient to take any other modular formula, especially in sport punya, because there's no clinical evidence that have been tried using this one, right? So apa yang kita practice memang pakai this aminoloban saja. So apa yang you boleh buat kalau patient complain with unpalatable taste of this aminoloban because it is seriously not a good one, doesn't have a good taste. Okay, we can suggest patient to take it while it is cold. Minum masa sejuk, boleh letak ais. We can make it into jelly ke, macam tu tak ada masalah. Minum sejuk lagi sedap dari minum suam atau panas lah.
Okay.
Okay.
As long as cukup dia punya BCAA lah.
Yeah.
Okay. Next question. If a patient with ascites and edema and the patient don't know about his or her body weight, how you determine the patient's dry body weight? How you decide on the body weight to calculate the energy and protein requirement?
Okay. So here in Selayang, most patient that come to the ward or need to be admitted will be weighed earlier. Memang masuk-masuk ward memang akan terus dia timbang lah. So I have never not really encountered any patient yang susah untuk calculate dia punya dry weight lah. Okay. So kalau usually dah ada tulis dalam diorang punya observation chart kat situ diorang punya weight, and we can also ask patient what is actually their usual weight juga kalau kita betul-betul tak boleh estimate patient punya dry weight. Usual weight without ascites lah, you dulu selalu berat berapa, kita boleh tanyalah macam tu. Then we can use either kalau betul-betul tak boleh sangat, we can use IBW at 22.5 so that we won't prescribe patient with too much energy and also protein.
Okay. Next question. Is there any improvisation from company to increase the palatability of their product? Or is there any way or innovation the facility done to increase their palatability?
As far as I know tak ada. I think the rep pun rasa macam tak ada new information on new flavor ke this aminoloban yang diorang ada. But macam saya cakap tadi, what we can do to improve the palatability on this product, kita boleh serve dengan sejuk ataupun actually we can add sugar inside kalau patient tak ada diabetic dalam tu untuk bagi dia rasa manis. Rasa sedap sikit lah.
Okay. Is there any clinical study comparing nutrition impact on patient with BCAA supplementation versus patient without BCAA supplementation with same protein intake?
Okay, so usually ada, okay, especially among there's few research study that's shown that memang BCAA supplementation can ada different result in especially the punya effect lah. The muscle wasting is to be seen with patient muscle protein loss, okay, less to be seen among this BCAA supplemented patient as compared to without BCAA. Macam tadi lah. Okay.
Okay. Next, what is your suggestion if patient can't tolerate milk-based oral nutrition supplement, especially during patient discharge home?
Can't tolerate milk base. So kita ada a lot of product here in Selayang. Kalau patient is not contraindicated, macam tak ada diabetic, we can just prescribe ada carbo punya, macam contoh we have resource dekat sini, so we can provide them with resource apple lah macam tu. Tak ada masalah pun actually to prescribe. And kalau tak nak oral nutrition supplement pun, we can suggest patient memang to take diorang punya snack lah. Every 3 main meals kena ada, then ada dia punya 2 snack and 1 late evening snack. Paling penting is actually the late evening snack, sebab just to reduce dia punya starvation period during tidur malam tu lah.
If patient is about to discharge and she need to be on oral nutrition supplement and she cannot tolerate milk base, so
yeah. Macam tadi, we can provide with other non-based oral nutrition supplement. Tak ada masalah pun.
So the patient need to buy.
Yeah, themselves. Bila dah balik, they need to buy themselves. We can suggest ada macam chocolate flavor ke, ataupun coffee flavor ke, ada nutrition supplement, tak ada masalah.
Okay. Next question, do you still restrict protein intake if patient having acute exacerbation of hepatic encephalopathy?
Usually
Acute hepatic enceph.
we don't restrict their protein intake. Macam Dr. Haniza cakap just now pun did mention that they won't restrict protein unless when we can actually unless patient there is no progress in patient. Usually we will monitor patient's ammonia level. So if there is an increasing trend of ammonia level, then we can try, but not restrict their protein. We just prescribe patient with normal protein, but not restrict at all lah.
Okay. Next question. Is there any biochemical marker that we need to look as evidence of the effectiveness of nutrition intervention given?
Usually kita for to see the effectiveness. So this liver cirrhosis patient usually comes and go in a very limited time lah. So sometimes kita tak boleh nak long term monitor dia orang punya kita nak tengok dia punya effectiveness of the intervention sebenarnya. But if patient has periodically masuk ward 3 minggu masuk ward 3 minggu masuk ward 3 minggu masuk ward for peritoneal tapping, so basically we can see if dia orang punya liver function test, either dia punya albumin level is static ke, increase ke, or even dia orang punya HP, are they taking enough energy and also protein.
Okay.
Saja.
Okay, is there any more question? I have one question. Okay, in your opinion, how soon, I mean, or what phase lah, we can recommend patient with liver disease to take BCAA supplementation, and any contraindication?
Actually, there is no contraindication for liver cirrhosis patient or liver patient lah. Sometimes patient that come is with early stage of liver cirrhosis or even does not even being diagnosed with liver cirrhosis pun kita boleh suggest patient to take them lah, to take the BCAA supplementation. Macam some patient comes because of fatty liver saja. Okay, actually we can prescribe them just for early preventions of ni lah. And also kita selalu cakap kat patient for liver protection, untuk patient punya liver protection, because fatty liver also can cause, in long term can cause liver cirrhosis juga.
Ada contraindication tak? Ke
Oh,
tak ada?
usually tak ada.
Alright. Any more question from the participant? Tak ada If not, we can finish early lah. But thank you again, Puan Aisyah, for the clear-cut answer.
Thank you very much. Okay.
I'm sure the audience will find the inputs helpful to them, and it was a great pleasure having you with us today. All right. So, ladies and gentlemen, before we end our session, please take note to fill in the feedback form and answer post-test question to obtain your certificate. And you can get the link in the chat box, and please fill up lah. Okay. So please don't leave yet. We will have a group photo session to commemorate this fruitful session. So I would like to invite everyone to open your camera for a group photo. Okay, so everyone can open your camera. The more, the merrier, right? Ada yang baru nak masuk lagi. Okay, host boleh ambil gambar nanti. Okay, boleh buka kamera semuanya. Boleh buka kamera, kalau tak ramai orang boleh buka mask. Oh, host please enable us. Host, sila bukakan host. Camera disable. Kejap technical issue. Buat mas boleh jauh.
All right, can I have cooperation since that we have more than 100 participants? So we will take page by page, yeah? So I think whenever we take, you'll just smile up because we won't know which page you appear, all right? So overall, we have 7 pages. So we'll go by page 1. Okay. First smile. Okay. Second page. All right. Okay, thank you. Second. Okay, we're going to the third. Okay. Okay, 1, 2, 3. All right, the fourth one. Okay. All right, the 5th page. Okay. And the 6th. And last but not least, the 7th. Okay, thank you everyone.
Thank you.
All right, that wraps up our evening session. On behalf of the organizing committee, I would like to thank you for making time to join us this evening and for your active participation. We hope we will see you again next time. All right. Thank you and have a pleasant day. Take care and bye.